All right. Okay, welcome to the final session of Topics in Geriatric Health Literacy Active Learning Series. My name is Tony Denuzzo, and I'm the Director of East Texas Geriatric Education Center. And I'd like to acknowledge our partnership with the East Texas AHEC, who have helped us get connected with the different groups. Today we have one speaker and one topic. Small topic, nothing major. It's all about the U.S. healthcare system and navigating challenges. And I'm going to introduce our speaker, Amanda Scarborough, in a little bit. We have learning objectives that it's an overview of the whole system. Again, the challenges in navigating it, emerging issues, strategies to address the challenges, and implications in terms of the new legislation going on with healthcare reform. This should be a really nice way to end this series that began in January. And I'd just like to say before I get into all the CE information that this has been a really challenging series to put together. I don't think a lot of people knew that much about what health literacy was, what it entailed and how important it was. And finding speakers that could know how to address those issues has been a real challenge. But I thank you all for your participation, your attendance and patience as we put this together. In terms of health literacy, I'd just like to say that I hope there's been a little bit more awareness and appreciation for how to better communicate with older patients. Communication is obviously real important, but the empathy that's needed has also been brought out. Maybe an nauseam in terms of how we try to express that. The topics, I think, have covered just about everything we could think of with health literacy, and I'm sure there's others that we may be able to still do. And this is the last in the series, and so I would like to thank several people with this. Okay, I'd like to acknowledge our program planning committee here at UTMB, Dr. Lee Grumbles, who internal medicine, represented medicine, as well as Dr. James Goodwin with the Seeley Center on Aging, who directs that center. Dr. Linda Rounds, who represented nursing, she's with the School of Nursing. Dr. Meredith Massell, Center for Eliminate Health Disparities, and she's a licensed social worker, and she represented our materials for social work. And Patty Crichton with the Department of Occupational Therapy, and she represented our allied health professions. So we were truly interprofessional, interdisciplinary, which was the only way to do it. I'd like to definitely acknowledge our administration, that there's no way I could do this without Beth Schilling's help with the CE, without Debbie Flanagan, who is no longer with East Texas AHEC, but contributed quite a bit while she was there. For Belengaria Navarre, who's taken her place and has helped tremendously with getting the IAHEC information there. Not last but not least with administration, Oscar Townsend has provided the lunch and food. So thank Oscar. I'd like to thank Biocom, especially Ray Karan, I'm sorry, in the back there, our video guy. Everything we have done has been recorded on video, and we have DVDs and copies of everything. And these will eventually be put on our website as video streamers. We've done this with everything we've done before. The quality is much, much better than we have. You could see every gray hair on my head now, you know. But we're really excited about getting that available and access for people to get on our website and view this information if they haven't gotten to see the previous sessions. Definitely like to thank Information Services Group that has provided our video conferencing, Veronica Pleasant, Kevin and Chandra Shumate. I mean, just an incredible group and knowledgeable, and they knew everything that had to be done to try and connect to different sites. And I would like to just say that I talked with them and to ask them, is anybody doing what we're doing in terms of trying to connect to sites? And while there's groups going on to out communicating and teleconferencing and video conferencing to other medical school groups, as well as with TDCJ and correctional management, we're the only ones doing this in this capacity, to be able to invite any group to join us through video conferencing. And There's plenty of challenges. We were just talking today that if one thing goes wrong with all the things that could go wrong, it could not work. So, but I really appreciate everybody's patience when we didn't get good signals or good audio or good video. But I think, as I was telling Dr. Grumbles a little while ago, it's good that at least we got it down pretty well at the end rather than not at all. So again, I really thank you for this, for helping this. Finally, I'd like to acknowledge, last but not least, the AHEC coordinators and who they are right there. Okay, I'm going to just switch this real quick so you can see who we have. All right. Okay, let me do this so you don't have to. Oh well. Okay. Right here we have Pecan Valley Victoria College there, and Jody Saunders and Paula Crawford are the IAHEC coordinators for Pecan Valley, and they could wave if they like. Hey, there they are. Good group, real good group. Here we have, that must have been Paula. This is Piney Woods in SFA in Nacogdoches. There's Mark Scott, the man, and everybody waving, and this is just a great thing to be able to do. I'm so pleased. Here we have Baylor University in Waco, and we have Amanda Thomas right there with Brazos AHEC, our coordinator. And here we have Lamar University, and I know we have Dr. Curl, and we have Terry with Coastal AHEC, and a lot of good groups, a lot of good people coming out there. We've done a lot of good work, hopefully, with all these sites. And one last thing I just want to acknowledge is that our proposal has been sent in, and we're in our last month of funding. No word yet on any results for, but they are reviewing applications. I feel really confident that we're going to get refunded and have 5 more years to do what we said we would do in our proposal, which is pretty extensive, but it's going to be great. Anyway, thank you all for participating. Just a great group. All right, let me get back here. All right. So, is there anybody I forgot besides everybody who's attended, and anybody who's participated in this? The CE groups, the people that help with the CE have been just great. Speaking of which, we offer free continuing education credits for continuing medicine education, for doctors, nurse practitioners, physician assistants. This has been approved for 3 credit hours for CME. All you need to do, there's a evaluation form for the CME, like an attendance form on the table. Fill that out, give it back to me. Make sure you sign in the sign-in sheet. I need to disclose that our speaker today, Dr. Scarborough, has no relevant commercial financial interests or affiliations to disclose. Okay, so now we are official. Okay. We offer continuing nursing education credits for RNs. LVNs will receive a letter of participation and attendance if they request it. Again, there's a separate packet available that needs to be filled out if you are interested in obtaining CNEs and you are an RN. And it's approved for 3 credit hours. We have 0.3 CEUs for physical therapists and occupational therapists. There's an evaluation form that needs to be filled out that's on the table. And then we have letters that we could also send out if needed. And anybody else that would like a letter of attendance, I'll send it to you. Just let me know. Okay. Any questions on CE or anything else? Okay. Okay. I'd like to introduce our speaker, who's going to be talking about navigating the U.S. healthcare system. Amanda Scarborough received her PhD in December 2008 with UTMB Institute for Medical Humanities, with a focus on medical ethics. Prior to that, she was on faculty at Texas State University, working and developing courses and instruction courses in long-term care administration. Her teaching and research interests include healthcare ethics and health policy and long-term care and minority access to healthcare services. I'd like to thank Dr. Scarborough. I'd like to thank Amanda for working with me on this. It's been really great. Just her knowledge of this is amazing, and I've learned a lot. Also, this was only going to be 2 hours of her presentation. I was hoping to get somebody for the older veterans. That didn't come out. We couldn't get the speaker to make it here. And I talked with Amanda just a couple days ago, say, do you mind doing 3 hours instead of 2? And she was great. She said, yeah, I'll add some things, no problem. So I'd like to thank you for your flexibility and willingness to help us. So, Dr. Scarborough.
Good afternoon. Thanks, guys, for coming. I know 3 hours is a long time, so we're going to try to do some breakouts. I have a video and a couple of cases and some problems, so it's not 3 hours of me talking, which would drive even me crazy. So we already talked about our learning objectives. Navigating the U.S. healthcare system and public health delivery systems is a complex task for anyone. Anybody who's ever had to utilize the healthcare system, I don't know if you've had to utilize it for yourself or your children, it's really complicated. And when you talk about seniors navigating the U.S. healthcare system, it's even more complicated for them. And I wanted to start with a case of how complicated the U.S. healthcare system can be. Mrs. HF is a 91-year-old woman who slipped in the shower and sustained a left femoral neck fracture. She has mild dementia and a remote CVA. Does everybody know what a CVA is? A stroke, right? HTN, so she has hypertension and she has hyperthyroidism. She lives with her children, walks with a cane, and enjoys attending a daycare program for patients with dementia. So she's in her children's home. She's not in a facility. She's living with her kids. Because of her advanced age, the orthopedic surgeon and her children are reluctant to pursue surgical repair of the hip fracture. So what are the key issues in this case? What are the major problems that she has and her children have and the physician have in terms of navigating the U.S. healthcare system? What do you think some of the major issues, just, you know, as an example, not to put you on to know some of the stuff we're going to talk about later, but what are just some of the issues that you think that she will have and her family will have and her kids will have navigating the U.S. healthcare system? Yes?
A couple of different ones that come to mind as far as ethically, should it be fixed or
Right.
not?
Right. And why would that be an issue? Ethically, why would it be an issue for her to be in consideration? Because it's her age, right? If she was 25, would we have this exact same issue? But she's 91, so it becomes an ethical issue because we're maybe thinking about not providing services merely because she's 91, right?
And then just the added strain for the family before she was able to get out, go to the daycare,
Right.
maybe daily, I'm guessing. So therefore, now she's going to be at home. Where is she going to go? What about the added expense if she needs to be like skilled facility
Right.
or someplace daily or maybe 24/7?
Right.
How's that going to affect the entire family?
Right, and so she's part of this, what we call the sandwich generation, right? Because she's 91 and she's living with her children, and her children possibly have children at home that they're caring for. So the children are taking care of their elderly mother and they're taking care of their younger children. So the added pressure and strain on the family unit, the children who are taking care of their mother and their children, and trying to balance and coordinate that at the same time. Any other sites? Do you guys have any issues, any problems that you see with this case that she's going to have, that her family's going to have with navigating the U.S. healthcare system? So the thing with this case, and especially with elderly and navigating the U.S. healthcare system, it's not just them navigating the U.S. healthcare system in many situations. It's their family having to figure out how to navigate the U.S. healthcare system for them, and in particular, the senior having issues with navigating and facing problems themselves. So why is it important for the elderly and their families to be able to navigate the U.S. healthcare system? I know you've probably heard about these statistics and talked about them over and over again, but older people use a disproportionately large share of the total U.S. health services in the U.S. Although people over 65 represent only 13% of the population, they consume 1/3 of all national healthcare spending. And if you've ever, I guess, talked about it, we spend the most money in the U.S. healthcare system on the last years of life and the first years of life. But again, because the elderly population is beginning to boom, and I think we have something about that with the aging of the baby boomers, the number of Americans over 65, which is 35.3 million, will double in size and approach 20% of the population by 2030. So using the most dollars in the beginning of life and the end of life, and we're seeing a boom with people who are 65 or older. A lot of U.S. healthcare dollars are going to be going towards that patient population. So why is navigating the U.S. healthcare system so complicated? It could be easy, right? But it's really not, especially for the senior group. The organization of the long-term care industry, there are multiple levels of care. It's not just one type of care. There's an informal system, a community-based system, and an institutionally based system. So when you're talking about providing care to the senior, it's not just them coming into the hospital, and it's not just them going to a nursing facility. We're providing care at multiple levels, and reimbursement is different based on where the individual is. We'll talk a little bit more about this later, but in an informal system, usually there's no reimbursement. If your friends and your family or your neighbors are providing care, there's not always a reimbursement for that. And that puts a major strain, especially when the informal system is a family, right? A daughter gives up her job to take care of her mother who's dying in her home. There's a lot of financial pressure, and there's not necessarily that reimbursement you would get in a community-based system or an institutional-based system. There's a great series that's done by Frontline, and we're going to watch a couple of parts of it about living old. And I wanted to show you some of the clips of the video that have to do with the different types of settings in which long-term care is provided.
A policeman told us how to go. Oh, when you're smiling, the whole world smiles with you. When you're laughing, what people like us need is lawyers.
I wrote to the Maharaja, and I printed it up in the page so they will see it out. You don't have to worry. I don't have to. They don't even know it's me. I just didn't give them my name.
Yeah.
I gave them my other name.
I'm just trying to say, when you have it, you don't get it. Even though I'm a nurse, I never imagined that I would be in a nursing home as a patient. Came in with a fractured hip, and been here 7 years now. No sense in crying over spilled milk. It's take things as they come.
Are you frightened of what's ahead?
No, I'm not afraid. I don't want to live forever. I hate to. I don't know. I hate to leave my daughter. That's all. Because she's 72 now. But she's doing all right.
Nearly 60% of those who live past 85 will go into a nursing home. And if they stay longer than 6 months, the vast majority will never leave.
One person I visit on a regular basis in the nursing home calls it, just the waiting room. And she views it as, this is where we all come to wait to die. In, some perspective, she's right. I mean, that's what happens, Other folks, I've seen people, who thrive there. I've had patients that were at home and then went to a nursing home, and they're much better off. The socialization, the participating in groups, having all these people around for meals is tremendous, and they live off of it and thrive from it. So it's not always, a downturn for some people.
Well, I left my home because I was lonely. When I read 95, 96, it was a little hard. So I had a friend here. So he said, come over, Clara, come over. It was all right. She was on the 7th floor. When I came, I said, look, you're not alone here. They're not friends. They don't know how to be friends. But they people. They people. And I get beautiful magazines. I get U.S. News World Report that for 50 years we have in our home. So I have the magazines, I have the newspaper, and they're people. They are people. Now, should we increase the taxes or cutting a government program such as food stamps, Medicaid, housing. The hardest time is I miss my old friends, and I miss my home. And then I say, look, you can have everything. So I try to be happy.
I don't know if growing old is easier here. In some ways, I think it's more difficult. I think it's a lot harder in some ways to keep your independence here. So you're much more dependent on families. Giving up independence is the worst. It is what everybody fears. It's what I fear. You have the cane in your left hand, and you move your cane forward and your right foot forward, and then your left foot.
Dr. Bill Koch opened his practice in upstate New York over 30 years ago. He's one of the few family physicians left in the area, and he sees thousands of elderly patients every year.
It's the doctor. So where's Mother?
She's in her chair.
Okay.
Yeah.
We still have lots of 3-generation households, 4-generation households. It's rare that people will give up and want to put somebody in the nursing home at the first sign of trouble. Most people will go through a long period of trying to take care of them in their own home or in the family home, or even extended families. Yeah, it's Dr. Koch. How are you? I'm happy to come out and see you here.
Oh, okay.
Yeah. Having a family really drives everything. I think it really gives people a reason to be better. It's really what their life is about often at the end of life.
Okay, so that shows you a little bit about the different types of systems, right? The formal, what they call institutional systems, which I really hate that term because it makes it sound not so caring, but the more institutionally type system, and the informal care, where you see the husband giving care to his wife in the home. So that informal type of system, you provide basic services: general supervision, running errands, dispensing meds, cooking meals, assistance with eating, grooming, and dressing. It's usually done by family or friends, and the family member stays either in their home or in their child's home, but it's a very informal type of system. And again, there's no reimbursement generally for these kind of systems of caring for the elderly. The community-based system is more formal services provided by agencies. They can be intramural systems like Meals on Wheels and home health. So they come to the individual's home, whether or not they're living independently or they're living in a child's home. Or extramural services where a senior citizen actually goes someplace, right? Adult daycare, senior services, so they are leaving the home to go outside the home to get services. The objectives of the community-based services are to supplement the informal system by giving care when advanced skills are needed and that families and surrogates can provide to address the patient's needs, to delay or prevent institutionalization. And again, I think that's such a harsh word, but instead of placing someone in a separate entity, keeping them in the home, and to provide temporary respite for families that are caring for seniors. The institutional system of providing long-term care runs on a continuum, and the continuum goes from providing the most independent senior, providing the least amount of care, starting with the continuing care retirement community, all the way to the specialized care unit facility. So you provide at the beginning level, at the continuing care retirement community, you have very independent seniors. They're getting housing in many cases, and some kind of other services like cleaning, maybe some laundry services, but they're really independent seniors. They can take care of themselves. There are social services where they maybe plan, bingo night or outings to go to see the movies, but these seniors who live in a continuing care retirement community are really independent seniors. They're just kind of in a smaller apartment type setting where there can be some supervision, some meals, that kind of stuff. Independent or retirement housing, it's again housing and apartment, so you still have a relatively independent senior. Social activities, laundry and cleaning. There are a few more services that are provided in terms of maybe helping someone put their meds in their med boxes, but again, they're really independent seniors. Residential or personal care homes are more like group homes, so where in the continuing care retirement community and the independent or retirement housing, they're living in an apartment or a little house by themselves. In a residential personal care home, it's a large home and each senior has a room or shares a room with someone else. And you're having more services provided. You're having your meals cooked, your room clean, your meds taken care of, transportation if you need to go to the doctor. Assisted living facilities are more help for the senior. It's more like a college dormitory facility. So you have hallways with many rooms where, in the residential personal care, it's set up like a home. You're moving more towards something that looks a little more institutionalized. Skilled nursing facilities, these are the long-term care, like we saw in the beginning of the video. When you think of, that's what skilled nursing facilities look like. Subacute, they're more intense ADLs being taken care of. For subacute care units, it can be either a wing of a hospital or part of a nursing facility, but again, it's more institutionalized, if you want to use that word. And specialized care unit facilities are for people with conditions like Alzheimer's and dementia, or people who are on hospice that require 24-hour, 7-day-a-week care. So that's kind of the spectrum of the care, from seniors who are completely independent and need a little bit of help to seniors who are completely dependent on 24-hour-a-day, 7-day-a-week care. So not only do we have these multiple levels of care that we're providing to seniors, in the long-term care industry, we provide a variety of services. We're providing medical care, mental health services, social support, and residential amenities. Medical care for the senior. Medical interventions in long-term care are primarily governed by two main health conditions: acute conditions and chronic conditions. Acute conditions are episodic and require short-term but intensive medical intervention, and chronic conditions are irreversible conditions that seniors deal with for many, many years. And we'll talk about later that the number of chronic conditions in seniors continues to rise, and caring for those chronic conditions is going to be something that we'll be facing when we look at the aging senior population. The medical aspect of long-term care has two areas of focus: preventing complications from chronic conditions and delivering treatments after acute episodes. In order to manage medical care, there's a lot of prescription drugs, right? There's a lot of ordering of prescription drugs, and seniors are some of the largest consumers of prescription drugs. I think the statistic is that the average person 65 or older is on 10 medications a day. And when you talk about health literacy and understanding dosage, timing, does anybody know the four? Is it dosing, timing, route? What is the fourth? There's one more. When you're administering a med. It's dosing, timing, route, and one more that I can't remember. Do you know? Okay. When you're
Right drug, right dose, right time.
Is that it? Okay. Right drug, right dose, right time. So when you're on 10 medications, you have to remember the right drug, the right dose, the right time for 10 different medications. Imagine how complicated that could be for you and a senior or their family member. If they're living in a family member's home, how complicated is that for their daughter or their son who's, you know, raising their children and taking care of their mother or father in their home to remember all of that information. And so elderlies represent 32% of prescribed drugs. The average number of medications of someone 65 or older are 10. And the average spending on meds per year is $670. Does anybody have any questions? Anybody out there? Any questions? Yes?
Back to your long list of assisted living versus skilled nursing and subacute, what kind of factors into the, I mean, obviously it should be medical need and functional requirements, but I mean, how does cost and patient preference, because that one lady in the first video or something was like, why don't you come over here to my skilled nursing facility? I mean, they can just go check in. What decision processes go into what level of care you go to, and is it typically you start there and get bumped?
Do you want to respond to that?
Usually for like a skilled nursing facility, it's being paid by your insurance company, so you have to qualify, like by diagnosis and stuff like that. The lady that was there because her friend was there, she may have been, because she talked about, I think about the other lady being on the 7th floor, if I'm correct, which may be like an acute care, and she may have been more in the general population type thing, because a lot of the nursing homes are divided up by that. Some even have a wing for Alzheimer's, and then you can move up or down.
But like Medicare probably pays for 2 or 3 of those as well.
Well, we'll talk about the Medicare a little bit later in terms of coverage for long-term care, but in general, when we'll talk about Medicare, I think there's a disillusion among the senior population that Medicare pays for long-term care. Medicare does not necessarily pay for a stay in one of these types of facilities. You have to have what's called a qualifying event. So someone has to have something happen to them. They stay in the hospital for 3 days. And there has to be a reason for them to go, and then they get 100 days. That's what Medicare covers. And it's called a benefit period, and you can have multiple benefit periods, and we'll talk about that a little bit later, but Medicare does not necessarily pay for someone to stay in one of these type of facilities.
I was just saying, I mean, just from I'm not really up on the literacy aspect of it, but I didn't know there was so many different, unique things.
Yeah.
If you showed an old person the list, they wouldn't know what care. So, I mean, do they find out from their doctor? Does their daughter do the research? I mean, because I just think it's kind of random where they end up, and it's...
Right. I mean, their social worker definitely plays a role in helping them decide where they need to go, and their physician and their family member. It's definitely I would say, a very complicated process finding out what type of assistance someone needs.
Right. Obviously, I think the financial ability plays into that a lot. In the proposal, we wanted to have a wider range of things that of experience activities that maybe the fellows or residents or medical students could get experience with. And one of the things we want to do is be able to have site visits as an example of all of these as an exercise. And I've been in contact with someone. I visited. Assisted living facilities are amazing. You have to be relatively independent and be able to qualify in that way. But when you go there, and there's 2 very, very popular activities that are almost ubiquitous to assisted living facilities. But there's a salon, a beauty salon, got to be there, and in the middle area, I've always seen this little golf area. They just play golf in one way or another. And those things, I mean, they're just vital.
And when we talk about the aging of the baby boomer generation, we're going to see more and more types of assisted living, nursing home, different types of facilities. I went to tour a assisted living facility in, I think it's like outside San Antonio area, the Hill Country, right? They're trying to put some in the Hill Country.
issue of the skilled nursing facility, because it's a rehab sort of facility, and the subacute care, which is also called long-term acute care, and that's sort of a step down from the hospital where they need some IV antibiotics, but they don't need that thermal supervision. They'll go to a subacute care unit. So these two would be covered. And the 100 days you mentioned is for the skilled nursing. Now, if they're in a nursing home where they do not need the skilled nursing, then they'll be nursing home long-term care patients, and that's what we saw in the video initially. The long-term care patients, they're not covered by Medicare.
Yeah.
And so what, I mean, we'll talk about that, I guess, a little bit later, but, you know, what happens to a lot of those people is they end up what's called spending down. They have their assets, and you have to get rid of your assets in order to qualify for something like Medicaid and be in a long-term care patient in a long-term care facility and spend and use Medicaid to cover your stay. And that's definitely a challenging situation when you think about, you know, you have married people, and they have there's some rules about being able to keep your home, but you want to spend down your assets in order for your spouse to qualify for Medicaid in order to be in the long-term care facility. But you know, you have to spend down your assets pretty deep in order to qualify for Medicaid, long-term care Medicaid. So it's a very complicated process. And anybody who's in social work, they are really skilled at being able to figure that out. Now they call, in order to qualify for Medicaid, people do what's called spending down, and they instituted a look back period. So you can't, you know, go into a hospital, have an episodic event, use your 100 days of Medicare, still need to stay in the facility, and then give all your money away, and the next day qualify for Medicaid. You have, I think the look back period is 5 years. Yeah, it used to be 3, and they just moved it to 5 years. So you have to have spent all your money 5 years prior in order to qualify for Medicaid. So people liquidate their assets in the anticipation sometimes that this is going to happen.
I was just going to say that the first couple of examples you have up there, I think you mentioned that there's a big trend now. I think a lot of the communities, like retirement communities, because my parents just moved into one. They lived out in the country, and so they have their own home. It's in a neighborhood, but it's all retirement communities. And so there is a continuum of care. Right now, someone else does the yard work. If any repairs need to be done, to even changing a light bulb, they can call somebody to come in and do that. There's like an alert light that they can call, and the ambulance will be there within seconds. But then it's a continuum of care. If they fall and break their hip, there's another part of that community, or they can even stay in their own home and they can get services come into their home. And so I think, you know, once you get hooked into one of these environments, like especially one of the first two, you may see that there's a lot of services offered on that continuum of care. And I think we're going to see more and more of that, because they really are trying to lure people to these different places. And they can offer, I would foresee that they would be able to offer all of those levels at one point.
They can.
Or contract out to do that. Or
it's expensive. I mean, that's the thing, is if you want to stay independent in your home and within the community, you know, your retirement community.
Almost guaranteed you can go to that next level, as opposed to saying now suddenly I want this extra separate. Good luck, Charlie. And it's kind of like Medicaid. I mean, yes, they've made more rules where you can't all of a sudden give half of your millions of dollars to your kids and then qualify for Medicaid, but try to find a Medicaid bed in some of the nursing homes or those, because there's only so few, because let's face it, they don't make the bucks, and that's what these institutions are all about. That's what medicine's become.
And I think, and I don't remember the percentage off the top of my head, in the long-term care industry, especially in this type of the nursing home, continuing care, retirement community industry, there are more for-profits than there are nonprofits. So when you have for-profit organizations, I'm not going to say that their mission is different, but you know, the drive is, you know, in order to, you know, the for-profit organizations have a different way sometimes of viewing viewing things than nonprofit organizations, which isn't always true. I mean, there are not the difference is, the big difference between nonprofits and for-profits is that where the money goes, right? Nonprofits, organizations, if you're a nonprofit organization and you make a profit, you have to put it back into your organization. If you're a for-profit organization and you make a profit, you can do anything you want. I say you can, go from the rooftop and throw dollar bills off if you want. You usually end up giving it to your stakeholders or your stockholders. But the difference, both types of organizations like to make a profit. It's just where the money ends up going. Anybody? Pecan Valley? Anybody out there? Nope. Okay. Okay, so we're providing medical care. We're providing mental health services, medical interventions in long-term care. Long-term care patients suffer from a variety of mental health conditions. Oh, wrong slide. Anxiety, depression, dementia. Mental illness represents a grave threat for older adults. Why do you think mental illness represents a grave threat for older adults? If they have depression and it's not diagnosed. Yeah, right. Barriers to accessing mental health services, knowledges of treatment options are not readily known as for physical illness. Treatment may be inadequate because diagnosis may be difficult. Unlike medical services, mental health services have a certain stigma attached to them, right? If you have a broken hip, great, we'll treat your broken hip. But, to say mom's depressed because she's in a nursing facility, we don't necessarily like to talk about that. Social support is necessary for older individuals to deal with the changing life events. Social support includes family, friends, neighbors, staff, any religious establishments that the individual is involved with. Part of the problem for seniors in dealing with their social support is, my grandmother is 96 and all her friends are dead, right? She says, I don't have any friends left anymore, all my friends are gone. So social support, that collegiality or that relationship with people of your same age that helps with our social support might not necessarily be there. Housing is a key component of long-term care because housing must be planned to compensate for people's disabilities. Housing is a really key aspect of long-term care. We don't think of housing when, you go to when someone who's 25 goes to the hospital to have a knee replacement. But when someone's 95, we think about what kind of changes are we going to have to make to their home environment to help them compensate. Do they need grab bars? Do they need, what are some ramps? What changes do we have to make to their housing to make them the most independent that they can be? Residencies must have physical features and amenities that are designed to promote independence. And there are a lot of rules about that when you look at some of these facilities, to how wide the hallway has to be, to how much furniture can be in a room, or how many chairs can be around the table. There's a lot of rules and legislation about the residential side of long-term care. So with a variety of services and multiple levels of cares, it's no wonder why the long-term care industry is so difficult to navigate for patients and their families. It's just so difficult. Again, I'm sorry, I didn't catch your name. Back to what James was saying, it's very difficult to navigate. We have so many types of services that can be provided, so many different levels, so many different places. So finding out what's the best route to get your services and the best services for the individual is very, very difficult. Okay, so here's another case. You guys want to take a minute and read it so I don't have to read it? Are you guys out there reading? Nod if you are. Okay, so we're going to discuss this case and then have a little bit of break. So what do you think the major issues of this case are? Somebody summarize it for me. Summarize the major issues. that Mr. G is experiencing? He's got a lot of chronic conditions, right?
He's alone.
His daughter checks up on him, but he's living alone. He's 64, is still pretty young these days, right? Yeah, 64 is pretty young. 64 is pretty young, but he's got a lot of chronic, persistent conditions. He went to the ER. He got another med. Right when he got an antibiotic. He went to the ER. He was in the ER because why? Why was he in the ER? Right. So how many meds was he on? He was on 19 pills a day, and he got another one. So what are the major issues? He's got chronic conditions. He's on a high number of meds. He's living by himself. So what do you think the challenges are for him to navigate the healthcare system?
Trying to communicate with 4 different doctors during an ER visit.
Right.
Has to be pretty chaotic.
Right.
And what are the chances of all that information being passed on accurately from doctor to doctor?
Absolutely. So he has a PCP, right? He has a primary care physician. What could his primary care physician do to better help him navigate the system so he doesn't end up in the ER? Is there anything that he can do?
He needs better medication management.
Yeah. Definitely he does. And he may not be able to rely on his daughter for that, right? His daughter may not be the one to pinpoint for medication management. Maybe he could give him a referral to a home nurse who could come and visit and make sure his medications are filled out his boxes are filled out properly once a week. What about himself? So what could he do to better navigate the healthcare system? His doctor can do something. He can do something. What can he do? Yeah, he needs to communicate better, and communication is definitely an issue when it comes to seniors, and we'll talk about that a little bit later. And we have a video on it a little bit later. So,
One thing that there's not money allocated for that I think would solve a lot of this is, anybody's ever built an ER, the first thing they tell you when you walk out the door is make a follow-up appointment with your PCP in 3 days.
Right.
And one point I used to think, oh, they're trying to cover themselves because if anything's gone wrong, they're putting it back on, quote-unquote, the family doctor to follow up, which is fine. But the problem being, maybe part of that is to really see how the patient's done since that time and maybe help eliminate some of these types of things from turning into major catastrophic illnesses. And wouldn't it be nice in a perfect world if every time a patient leaves the ER, the next day they can get a follow-up call from someone with some clinical background that could ask questions and the right questions and leading questions to these types of people that maybe they could get the care that they really need before it develops into a complete cellulitis where perhaps the gentleman could end up losing his leg and all this because of infections.
Yeah. Don't they usually, when you first come in, do the brown bag with the medications, bring in all your medications, see what you're taking. Yeah, to have some idea that, well, okay, along with all these others, I'm going to give you 7 more or whatever, and that's insane. But him being 64, is that across the board, in terms of patients? I mean, a geriatrician will think of that, I'm sure, that's what they do. But PCP doesn't have a lot of experience with someone that has multiple medications like that. Will they be more likely to say, why don't you bring everything you're taking in, put in a bag, and we'll take a look at it and sort through it and see what you need to take, and see what has synergistic effects and all these other.
like you're saying, the PCP is not anticipating that level of complexity. Right. Absolutely.
Yeah.
Right.
I would imagine at 64 you might have that.
Yeah, but 64 is still young. I mean, 64 is still really young, and we're looking at the.
But you look at diabetes and hypertension, that should be your first clue. Almost all of those are going to be a couple of pills apiece, basic.
Right.
And how many follow-up besides the questions of, are you okay with taking this? And are you okay with lots of other services? You make sure one of those kind of conversations would be, between that, especially that fifth doctor who can be prescribing.
Well, and you have to realize too, in the ER, they're dealing with this gentleman, but now they've had 4 ambulances come in, and you know, obviously that's, quote, I'm not trying to point fingers at her, but that's our main focus. I mean, they're ER. Not that this isn't important, but on a scale of things and in triaging, who's going to get the most care, the most time of those healthcare givers? It's scary. I mean, I look around and go, what do these poor people do that don't have anybody to follow up on them, or, you know?
Yes, because in an ideal world, the hospital with electronic records, the primary care physician would be notified, someone from his office would contact the person and say, you need to come in.
Right. Yeah. That'd be a great system. In general, there are some major challenges to navigating the U.S. healthcare system. Like the long-term care industry, the U.S. healthcare system is complicated to navigate. So I think we've talked a little bit about that. So that's the first thing. The U.S. healthcare system, the long-term care system, they're both pretty complicated to navigate. And the number 2 issue number 2 challenge to navigating the U.S. healthcare system is that there's increasing pressure for the patient to make health management decisions. There's a lot of push these days for patient-centered decision making about what the course of their health care is going to be. They'll give you get options, right? You can do this or this or this or this, right? Your physician often presents you with options. And so there's a lot of pressure on the patient to make that decision, which requires a high level of understanding on the patient's part. Some of the stuff that you get when you're given options can be so complicated, not only for the average adult, but for the senior citizen. Think how complicated the choices can be, and in the way that they're convened to you, the terminology, the time frame that you're given to make a decision, it can get really complicated having to make your own decision. The information the patient receives from the physician, written and verbally communicated, is complicated and difficult to understand, and the information from their health plan is difficult to understand. So not only is the system complicated, but there's pressure on the patient to make their own decision, and the information you're getting from your doctor is confusing, and the information you're getting from your health plan is confusing. Has anybody ever tried to look at their own health plan and read all those pages of papers about what your responsibility, the patient's responsibility is? It's incredibly complicated, and you don't really sometimes understand it until you've tried to use it. I have a 2-month-old baby, and I had a delivery, and then I got a bill in the mail for his care, and I was like, well, wait a second. I know that because when he's born, for the first 30 days, he should be covered on my plan, so shouldn't his deductible be covered under my deductible? Why am I getting a bill for his deductible? And so I called the pediatrician or the doctor's office, and I was like, well, why am I getting a bill for a deductible for him? It should be covered under my deductible. And they were like, oh, okay, that's right, you don't have this bill. So understanding your own health plan is so difficult, and standing up for yourself and what your portion of your bills are increasingly complicated. I mean, if I had not known, I might have just written that check, right, and sent it off in the mail. But I knew from being involved in healthcare that he should be covered under my deductible, and he shouldn't have his own. So that saved us $1,000, right? So seniors continue to age. You get more seniors. You get more people who are 65, 75, 85, 95. Like I said, my grandmother just turned 96. You get people in the seniors, the older of the seniors. You have trouble navigating the U.S. healthcare system because of all of these type of conditions that are coming along with it. Chronic disease and self-management, patient-provider communication, patient safety and health quality, access to healthcare and preventative services, healthcare provider time limitations, healthcare expenditures, and consumer-directed healthcare. Oops. Chronic disease is a critical issue in healthcare in general, not just for the senior population, but especially for the senior population. Chronic disease is a definitely on the rise in the patient population and the senior population. Care for chronic disease is more difficult for providers, families, and patients when they cannot understand or remember the directions, or when the directions are given and are incomplete and and unclear. For the elderly, 12.2 million or 23% of all people over 60 years or older have diabetes. So diabetes constitutes a chronic condition, right? Chronic maintenance requires chronic management, and understanding the implications of unmanaged diabetes, understanding how to manage diabetes, not only for the patient but their family, can be a very difficult proposition. The elderly is one of the fastest growing segments of the population, have the highest prevalence of hypertension, and account for a large portion of persons seeking antihypertensive treatment. So again, chronic disease is on the rise in the general population, but especially prevalent in the elderly population.
Funding for Frontline is provided by the Park Foundation, committed to raising public awareness. Frontline is made possible by contributions to your PBS station from viewers like you. Thank you.
Tonight on Frontline, Americans 85 and older are now the fastest growing segment of the population.
I remember being repulsed by wrinkles and gray hair. And now they're just a part of life.
Medical advances have enabled us to live longer, but not always better.
Another bypass surgery, another transplant. Nobody's bothered to think about what the repercussions are of trying to keep people alive longer and longer with such a limited ability to function.
It's an economic as well as a human demand on strapped middle-aged and middle-class families. They're still caring for their children when they're also caring for mom and dad.
But this is really a story about confronting the inevitable.
I keep trying to fix things, and even though my head says I can't, your heart wants to fix everything.
And coming face to face with our own hopes and fears about living old.
I like life. I like it. But it's not up to me. It's not up to me.
I'm Estelle Strongen. I was born on May 30th, 1911, which, if my arithmetic still serves me, makes me 94 and a half. All right, so who else has it? Who else has it? I'm what was once called a stockbroker. Okay. Buy 500 each. Today we have the rather elegant title of financial advisor. All right, buy 500 HOLX for 82836. And I still, even though I'm 94, I still have ambitions. And one of them is to do the job well. I know we're chasing it, but they missed it, so we're going to chase it. I was never one of the people to be horrified as the decades passed. Except I have to admit that 90 was a little intimidating. I thought 90 meant the end. And I'm a little surprised that it hasn't.
I'm 99 years old. I'll be 100 in 2.5 months.
How's that feel to almost be 100?
It's the same as 99.
Never, never, never did I think I'd live so long. I couldn't even think about ever living so long.
I don't know, I'm a little frightened. I don't know anybody was 100. Is there a change? Is there change? Yes.
We're on the threshold of the first ever mass geriatric society. And it is, in many respects, really a wonderful time to be old, because people are not only living longer, but they're living healthier into their 70s, 80s, in some cases even into their 90s. That's the good news. The bad news is the price that many people are going to be paying for this extra decade of healthy longevity is up to another decade of anything but healthy longevity. In fact, more and more people are living long enough to suffer from the as yet incurable diseases of body and mind.
I think the biggest issue facing the population of patients is loss of function. You begin to learn that not everyone has cancer, not everyone has Alzheimer's or Parkinson's, but almost everyone loses function. And by function, I mean it could be something as simple as slowly worsening vision, or really bad arthritis in one knee that makes it harder to get around.
People want to live longer, but they want to live longer in the self that they have at that moment. And so if there was a way that we could keep you in your 40-year-old body until you were 100 and then you drop dead, that would be a major medical advance. But unfortunately, as time goes on, these chronic diseases take a toll on the body.
I don't think that any of the lessons of gradual loss of one's bodily powers really are preparation for some of these long-term conditions of enfeeblement and frailty. One should just simply tell the truth. No one wishes that for oneself or for one's loved ones. The question is, it's here. If it's not going to go away, how can we still make something out of it?
Let me make you an appointment, okay? Okay, I'm going around here.
Over the next 30 years, the number of people over the age of 65 will actually double, to the point that they're about 20% of our population, about 70 million people.
Ms. Schiller?
Yes, ma'am.
Come with me, please.
Excuse me.
Years ago, people died of pneumonia and flu and tuberculosis, infectious diseases, and we've become much better at treating these sorts of things. And now people are dying of their chronic diseases. Things like high blood pressure, hypertension, heart failure, stroke, diabetes. These are all things that require management over time.
Yeah, thank you.
Now we're dealing with older folks who have multiple chronic illnesses, but are still kind of able to maintain their status quo, but any little something's going to tip them over.
Hi, Mr. Mikhailowicz.
You know, it's that frailty where anything happens on top of it, you expose all of the underlying disease and disorder that was kind of masked by the other systems that were compensating for it.
Oh, okay.
Our system is set up to really treat acute diseases. Our system is set up to treat with procedures, and it's not set up to treat chronic diseases and to take time to figure out what's going on.
Where do you want me to go?
I want you to have a seat right over here. Oftentimes you can't get to the heart of the problem until 15 minutes into your conversation. And with the way healthcare is today, you may only have 15 minutes for your entire visit.
Just a little bit more.
I have trouble with the urine.
You have trouble what?
With the urine.
Yes. What's happening with the urine?
I don't know. I make wet.
Okay.
And I can't hold it.
You can't hold it in?
No.
How long has this been going on for?
For a while.
Like a few months or just a couple weeks?
A few months.
Months. Okay. Does it happen every day?
Yeah.
Yeah. Let me close the door.
More. I want this. You see, I forgot. I forgot.
That's okay. It's all right. Take your time. It'll come up. It'll come up. Don't worry.
Provider-patient communication. Health literacy is not the only factor that affects provider-patient communication. Patients with limited health literacy have problems with literacy and numeracy related to the tasks in the healthcare setting, as well as problems understanding verbal communications. And patients with limited health literacy are less likely to challenge and ask questions. So if they're not understanding what you're telling them or what's the, the dosage, they're not asking questions, what's going to end up happening? They're going to get it wrong, right? If they're not getting the right information and they're not asking questions, they're going to maybe guess. And when they guess, they may end up getting it wrong. And when they get it wrong, what's going to happen to them? Yeah, bad outcome. They might end up in the ER. They might, not a good thing. Health literacy is not the only factor that affects provider-patient communication. Cultural competency affects provider-patient communication. And we've talked a lot, I'm sure you've talked and heard about cultural competency a lot. But when we're talking about cultural competency in seniors, the thing that we have to remember is the elderly population, the cultural diversity of the elderly population is changing. We're not just, one ethnic group aging. From 1990 to 2050, we expect to see the white elderly go from 13% to 23%, Black elderly from 8 to 14, and Hispanic from 5 to 14%. So you're having a change in the diversity, the cultural diversity of your senior citizens, and that's going to require different methods and varieties of communications with these individuals, with these seniors. Patient safety and healthcare quality. Lack of cultural competency and inattention to health literacy can both compromise patient safety through a number of mechanisms. For example, a variety of problems can result if cultural and language are not taken into account, including failure to get an accurate history, failure to obtain informed consent, poor health knowledge and understanding of health conditions, medication errors, lower utilization of prevention and other healthcare services, and poor patient satisfaction. So if you're not taking, or people are not taking into account health literacy and the cultural issues of communication, you can have all sorts of problems.
I want to say from where I heard an Alberta wing in their downtown hospital, an Asian wing of the hospital. So it's all Asians that are admitted there for whatever reasons, all ages, but they serve their type of foods, just everything, their culture, their provided.
So focusing on doctors, different type of medicine, Western versus Eastern type of delivery of medication.
Extensively, but just that these people feel comfortable.
I had not heard that.
Automatic. I want to say it was 2 weeks ago I heard that the news or better, which brings up a whole nother. So now do we need a wing for every type of culture? And obviously you want to be good, these people feel comfortable, the people taking care of them would know a lot of things already, whereas say I'm walking into that environment would be going, what did I say wrong, or what did I do wrong, or why don't you eat this food,
right?
Those types of things like that. And in particular, in relating this to the elderly, and the fact that we all know that elderly usually like things kind of the same, it's easy for them to digest, as opposed to have to figure stuff out because it's different for them. Is that something that could go on for the future? And if so, do we have to do it for every culture?
I think you're going to see cultural diversity in the long-term care delivery system. Like I said, my grandmother's 96. She lives in the Midwest. She lives in South Bend, Indiana. And you even see diversity in the type of foods that are served. You go up there and it's kind of comfort foods for people who grew up in the Midwest. A lot of casseroles and those types of foods. So you see some kind of cultural diversity already, but it's more geographic. Versus I just have not heard. I had not heard about that, but that's very interesting.
You could probably go with the numbers in terms of the demand in the area, in that area especially. There's a very high Asian percentage population, I'm pretty sure.
Somebody's got to be funding that.
Oh, yeah. Yeah. Somebody.
The hospital wouldn't have just done it because they have a lot of patients.
Well, and then you look at somebody, we had this discussion at one of our nursing leadership meetings not too long ago, and somebody said, okay, look at the insurances of sometimes that population, and that population many times takes care of their own as a group.
Right.
So they may have a tendency to get better quicker and be able to kind of fund that, and that, hey, you build it, they will come type thing, but they will come with insurance money.
Yeah.
Versus maybe a different, diverse population.
Well, I know, like in long-term care, Hispanics historically were not going to do not use long-term care.
Right.
And but that's changing a bit. And part of that, some long-term care facilities are going beyond making sure that there's not just language communication, like just somebody who speaks Spanish on staff, for example, or even in the hospital, but they're more cultural sensitivity where they are celebrating the holidays, the traditional Mexican holidays, for example, or the food that they provide. That cultural sensitivity is becoming a little bit more pronounced, a little bit more aware, and they're taking it. And they're seeing advantages. They're getting a wider range of residents, possibly more people. I don't know. There's more of a trend, I think, towards that. It's a way to go.
Access to health care and preventative service. Access to health care is complicated for everyone. When you look at access to health care, they call it the iron triangle. It's cost, quality, and access. Financial, it involves finance. Can I afford to go to the doctor? Availability, access. Is it there? Are there providers for me to see? Will they have the time to see me? And in this issue, when you're talking about access, we talk about transportation. Can you actually get to the doctor? And this is really important. These three issues, finance, availability, and transportation, are really important when you talk about senior citizens and their access to health care. Finances, can I afford to go to the doctors? For many seniors, obviously you guys know they're on a fixed budget. They're living off of their retirement or their savings, and going to the doctor, the financial cost of the copay or the deductible or any of the medications that they have is something that they're going to have to take into consideration. Can I actually afford to go to the doctor? Availability, and back on that video that we watched, are there providers to see? The number of gerontologists, the number of people who are there to serve the senior citizen population is just not there. There are not people who go into geriatric medicine. At least 20,000 gerontologists are currently needed for the 35 million Americans over 65, but only 9,000 out of the 650,000 doctors in this country are certified in geriatric medicine. Every year, 16,000 students graduate from medical school, with another 7,500 coming from abroad. Out of these, only about 500 or 2% go into geriatrics. So we're not having the movement into geriatrics to serve the patient population. And as Tony mentioned, some people, if they can't find a geriatrician, go to a PCP, but there are issues with going to someone who's not necessarily trained or particularly trained to see that patient population. Again, with access for the elderly or the senior citizens, transportation is definitely an issue. Can I physically get to the doctor? Can I drive? Am I able to drive? Can I get a ride with my neighbor? Is there public transportation? If I get on the public transportation and get to the doctor, will I be able to get home, right? Can I get a family member or a friend to drive? Do I have to call a taxi? So physically getting to the doctor can be quite a challenge for the senior citizen elderly population. And again, back to that video that we were watching, providers have limitations. There's a limit to the number of providers that there are out there, and there's a limit to the amount of time that they can spend with patients. Most insurance plans do not reimburse for time spent instructing patients on how to manage diseases. I had a friend at Texas Children's Hospital who was the manager of one of their clinics, and he said that they block out a certain number of time for a patient visit, and it's usually 8 to 10 minutes. So they try to squeeze five patients into 1 hour. And when you go back to the chronic conditions and you think about that, the video where he was having the conversation, it's gonna take more than 8 to 10 minutes to get to some of those issues, and limiting, your visits to one visit every 10 minutes, and then you have to account for paperwork and prescriptions and filling out all that kind of stuff. 10 minutes with a patient is not a lot, and in this population may not be enough time to get to what you need to get to in order to help them manage their condition. So it's nearly impossible to deal with literacy and language and cultural issues in a 10 to 15 minute patient visit, and you're lucky if you get that 15 minutes.
When you think about it.
Absolutely. Yeah, I mean, 10 minutes per patient.
You have to count that in because you only have so many rooms to fill before you got to get one out to get the next one in.
So for the elderly, multiple medical conditions can make caring for them challenging. Again, it takes time to talk to patients, it takes time to get to their issues, it takes time to explain to them what they're going to do, and in that 8 to 10 minute window, it's very difficult to accomplish. Okay, healthcare expenditures. Healthcare expenditures are an emerging issue in navigating the U.S. healthcare system, and I'm really interested to see what the new legislation is going to do to this, and I cannot shake my crystal ball and tell you what's going to happen, but this is where we are right now with healthcare expenditures in the United States. Healthcare expenditures in the United States rose from $106 per person in 1980, or $255 billion, to $6,280 per person in 2004, $1.9 trillion overall. That's a lot of money, right? That's a lot of money into healthcare. That's a lot of money. During this period, healthcare costs grew faster than the economy as a whole. As a consequence, healthcare spending now accounts for 16% of the GDP, the gross domestic product, compared to 9% in 1980. The GDP in the United States, this as of 2010, this is where we are, 17% spent on healthcare, 15% on education. So we're spending more on providing health care in the United States than we are on providing education. More on health care than we are to providing pensions. More on health care than we are to providing defense. So this is where we are right now in 2010 with the GDP and our spending on health care. And I think it breaks it down by state, and you'll be, when I show you this, to me it was shocking. We're spending 35%, 35% of the GDP in Texas is healthcare. 35%. That is a ton of the GDP on healthcare. Again, more than education, more than pensions, more than transportation. 35% of the GDP in the in Texas spent on education. Healthcare, sorry. U.S. healthcare is expensive. The elderly, 65 or over, make up 13% of the population in 2002, but they consume 36% of U.S. personal healthcare expenditures. The average healthcare expenditure in 2010 was $11,089 per person for an elderly person, but only $3,352 for a working age individual. So the elderly or the 65 plus are spending almost 3 times what the working age person does on health care. I don't know where it is. But I'll tell you that in terms of even as high as our spending is, we are not number one, I'm sure you know, in terms of life expectancy and infant mortality. The U.S. is, the comparisons were Japan, Switzerland, Germany, Canada, and we're behind them in our life expectancy and higher than they are in infant mortality. So we're spending a lot of money, but the question is, what are we getting for our health care?
Did it talk about why that was?
No, I don't think it did talk about why that was. But that is that's a separate conversation, and that's a very interesting conversation too. 25% of the U.S. community population reported to have one or more of the 5 major chronic conditions: mood disorders, diabetes, heart disease, asthma, hypertension. Spending to treat those 5 conditions alone accounted for $62.3 billion in 1996. When other illnesses are added in, total expenses for people with these 5 major chronic conditions is $270 billion, or 40% of the U.S. healthcare cost. So we're spending a lot on managing these major chronic conditions, and we already talked a little bit about the senior population and their prevalence of these, some of these, the diabetes, the hypertension, the heart disease, prevalence of these chronic conditions. Right now, there are two major programs, and I say right now because we don't know, we have that legislation out there and we're interested, I think, all in seeing what's going to happen. We have the two major programs that are funding or are revenue streams for long-term care, Medicare and Medicaid. In 2001, 5% of Medicare fee-for-service beneficiaries accounted for 43% of total spending, with 25% accounting for 85% of all spending. Chronic conditions were closely linked with high expenditures levels. And the top spending, 25% Medicare beneficiaries incurred an average person cost of $24,800. Does everybody know the basics of Medicare, who Medicare covers? That Medicare covers those individuals who are 65 or older, and it also covers a special carve-out group of people who have end-stage renal disease. They're included in the Medicare beneficiaries, but Medicare, obviously, we know is designed for the senior citizens. We all know about that, okay. Okay, so when it comes to Medicare and seniors, I think that there's a little bit of confusion. I talked a lot with a social worker who worked in a long-term care facility. I think there's a lot of confusions about what Medicare covers. People come into a long-term care facility and think, I have Medicare. I owe what? Why am I getting a bill? I have Medicare. They think that Medicare is automatically going to cover their stay in a long-term care facility, but we talked a little bit about that earlier, and that's not necessarily the case. Medicare does not cover care at all if all an individual needs is custodial care. If all they need is some kind of care that helps with your ADL, so your activities of daily living, including getting out of bed, eating, bathing, dressing, Medicare is not going to cover it. Medicare covers nursing home care if an individual needs skilled nursing or rehab. Further, Medicare will only cover skilled nursing or care for a short period of time. To qualify for Medicare skilled nursing coverage requires a qualifying event. Okay, a qualifying event is someone who goes into the hospital, is in the hospital for 3 consecutive days, and you are social workers out there that work in the long-term care setting are very smart about how they do this. It's a 24-hour, process. You don't want to release someone on the 23rd hour of their 3rd day. You got to wait till that 24th hour for it to constitute a day. They know how the social workers who work in this long-term care setting really know the system pretty well. But it's 3 consecutive days in a hospital, and that stay will result in what they call a benefit period. A benefit can last up to 100 days, and I've seen it where someone goes into a long-term care facility and they're there for, 60 days, and then they start getting a bill, and they say, well, why am I getting a bill? Well, I had 100 days. Well, you stopped getting rehab at 60 days. So now it's your responsibility, your family's responsibility. They can get that 100 days. They don't necessarily get them. They're not entitled to them. They have to continue to rehab. They have to continue to make some kind of progress. There has to be a rehab or a need for them to get that kind of care. So it can be shorter than that 100 days. And an individual can have more than one benefit period in a year. A new benefit period will begin after another 3-day hospital qualifying event. So you can have many, many benefits periods within a year. Okay. Mrs. Perkins receives 10 days of Medicare covered SNF care after she was hospitalized when she broke her leg. Her Medicare coverage ended when she stopped needing skilled nursing. She chose to go home rather than pay for the custodial care. So she's in a nursing facility, she's getting rehab, she goes home, and she's home for 10 days. And after 10 days, her doctors decide that she needs to go back. Will Medicare cover this stay? Will she get Medicare stay? Actually, she does. She does. She's home. She's not home for a longer period than 30 days. She goes back into the nursing facility and she'll get coverage. But how much coverage will she get? How many more days can she get?
At 100%, she'd get 10 days, right?
She's not going to get 100%. She gets 10 days covered at 100%, and then she has additional days that she'll have a copay. So she can get the rest of her days, not necessarily the full 100, but she will get covered because her stay was out of the facility less than 30 days. If Miss Perkins went home and she broke her leg and she was home for 31 days, and then the doctor decided that she needed to go back, she would not get coverage because she's been there's been a break in her care. She's been out of the nursing facility for more than 30 days. But because she was home for less than 30 days, she'll get back that 100. She'll get back a portion of that 100 days. It's not a new benefit period, so she doesn't get a full 100, but she gets back a portion of those 100 days. Okay, Mr. Jones receives 20 days of Medicare-covered skilled nursing care after he was hospitalized when he had a stroke. His Medicare coverage ended when he stopped needing skilled care. He chose to stay in the skilled nursing facility and pay for the 2 days of custodial care. He then went home. After 34 days, his doctor readmitted him to the hospital for 4 more days because he had a stroke. He was then admitted to a skilled nursing facility because he needed care. Will Medicare cover his stay in the skilled nursing facility? Yes. Why will it cover? Because he had another qualifying event. He went home, he was admitted to the hospital, he had a stroke, so he gets a full another 100 days of care because even though he has to pay for the 2 days of custodial care, he was home for 34 days. He had another qualifying event before he went back into the facility, so he's covered.
So even if it's the same kind of event?
Yeah, it's any event any kind of medical event that's going to require a 3 or more day hospital stay. Okay, Mrs. Smith received 20 days of Medicare-covered skilled nursing after she had back surgery. Her Medicare coverage ended when she no longer needed skilled care. She went home. After 65 days, she was hospitalized for 3 days due to a fall. When she was then admitted to the SNF, because she needed skilled care. Will Medicare cover this day? Yeah, she was out of the hospital. She had a break in care. She had another 3-day qualifying event. She gets her full 100 days all over again. So see how you can get more than one benefit period in a year? She had a benefit period of 20 days. She went home, just like Mr. Jones spent time at home, then had another event and gets her another benefit period. So you can have many, many benefit periods within a year. It just requires that 3-day hospital stay for a qualifying event. Do you guys have any questions about that?
So if she was in the skilled nursing facility and she had another event and spent 3 days in the hospital, would she qualify for another 100 days?
She's in the nursing facility. She has a stroke in the facility. They send her out to the hospital. She's in the hospital for 3 days and then she comes back. Will she have another 100 days? I don't know. I don't think so. I think she will have the remainder because she hasn't been away from the facility. You have to have a benefit period. You have to have a medical event, and have a break in care. Be away from the facility, like Mr. Jones, and
the length of the break
has to be more than 30 days. So if she was in the facility, had a qualifying event, she gets the remainder of her days. Yeah, you have to have a break in your care, not just an episodic event. They have to go together. An episodic event, like some kind of stroke, that kind of thing, and a break in your care. So you have to have the break in your care, obviously, probably before your episodic event. And not only does Medicare not always cover long-term care or skilled nursing facilities, it's not 100% paid for, like you said. Days 1 through 20, Medicare pays for it all. But days 20 through 100, there's a benefit of the benefit period. Medicare pays all but the copay, which is $128 a day. And that's the last time I checked. And I don't know if it's increased. I don't know if anybody knows out there if it's increased. But it's $128 a day. And the patient is responsible for that. Whether or not they have insurance or Medigap or something that can pick up, the patient is responsible for $128 a day for days 21 through 100, and that can get pretty pricey if you're looking at, days, all those days. If you do 100 days worth of your stay, that can be pretty expensive. So here's this slide that I couldn't find earlier about the percentage of the GDP, where the United States is at 15.3, Japan at 8, life expectancy. United States, the life expectancy, average life expectancy 77, Switzerland 81, 79. You can see across that again we're the highest in terms of percentage of the GDP and the amount we're spending, but we have the lowest life expectancy and the highest infant mortality. So, the question probably will always arise, what are we spending our money on? Well, that is a good point. In Japan, that is a very good point. That's right. Yes, I have 4. I know. They're shortened each one is shortened my life expectancy. Okay. So the other major funder for long-term care, other major public program is Medicaid. You guys know that Medicare is a federal program, that Medicare is run federally, while Medicaid is a state-run program. So there are as many states as there are in the United States, there are different Medicaid programs. Each state can design what they want to cover in terms of Medicaid. The federal government sets a floor. You have to provide these services, but not a ceiling. So you can go up and beyond of the services that you're providing, but there is a limit to the services that there are services that you must provide for Medicaid spending. The elderly and disabled, who constitute 25% of the Medicaid population, accounted for 70% of Medicaid spending services in 2003. People with disabilities accounted 43% of Medicaid spending, and the elderly 26%. The remaining 75% of the Medicaid population who are not elderly or disabled only accounted for 30% of spending. Okay, and I have one more short clip from the movie to show you guys.
With fewer doctors now available to care for the rising number of elderly, many worry we're on the verge of a national crisis in care.
Nobody's bothered to think about what the repercussions are of trying to keep people alive longer and longer. Another bypass surgery, another transplant, without anyone worrying about how do you get them physical therapy? Will they ever walk again? Can they swallow their food? It's not a very thoughtful way, I think, of providing health care. Medicine has changed, I think, appropriately in terms of the technology that's become available and the fact that we can diagnose people and we can treat them and we can cure them in some instances. The problem, I think, is that the pendulum swung too far. And so the focus over time became predominantly diagnose, treat, cure. Good morning, how are you? Dr. Janowitz? Even when there's nothing, quote unquote, medical to do, you still need to be there for someone.
As more and more people are becoming too frail to leave their homes, many doctors are once again making house calls.
Good morning. Early today, huh?
David Muller, one of the founders of Mount Sinai's Visiting Doctors, provides medical care to a growing number of the city's homebound elderly.
I'm just going to try to write him some notes so I can at least say good morning.
My name is Dr. Muller.
For the past 3 years, Henry Janowitz has been wheelchair-bound. A former physician, he is now nearly deaf and has severe arthritis.
Okay.
Yeah? How about your knees? Pain? Here.
Yeah.
Here?
No.
No, only here. Each of us, whether we're in the baby boomer generation or not, as parents, and we watch our parents get a little bit older, and even if they're relatively healthy and functional, you sort of see the slowdown and you anticipate, you try to plan ahead for being able to be around and care for them, and at the same time you've got a family of your own and kids and a job and career aspirations. And so it's an unavoidable part of life. And I haven't figured it out for myself either. As far as my parents are concerned, I'd like to believe that I'll be there and be available for them whatever they need and whenever they need it. But I don't know if that's really going to be the case.
What are their expectations of you? Do you know? Have you had those conversations?
We've had the beginnings of those conversations, probably mostly because of the work that I do. I think their expectations are very typical and very traditional. None. Zero. You know, they don't have any expectations that they'll move in with us. They don't have any expectations that we'll have to do anything extra for them. They don't want to be a burden. They'd like to stay independent.
Dr. Janowitz is a widower, and his daughters live too far away to be involved in his daily care. So he pays $150,000 a year for the 24-hour help that he now needs to stay home.
The level of home care has gone up because we have so many medical procedures now and interventions that we didn't have before. Often they're, really complex things going on that have to be done in the home.
Hi, good morning.
So it's become much more complex. It's not just taking blood pressure and filling up a medicine box.
How you doing? How's she doing today?
All right, she's awake.
That's good. Hi, Mrs. Enoch. How you doing?
I'm doing okay.
I'm Lillian, the nurse.
Yes.
I came to check your blood pressure and do your dressing on your leg.
All right.
All right.
Okay, I've just got to lift your leg a little, Mrs. Enoch, okay?
Our goal is to make whatever time the person has left be the best and most comfortable that it can be. Because a lot of these things have been going on for years and years and years, and they're never going to go away. And everybody has the fantasy of dying, by just going to sleep and everything, not feeling anything and everything's great. You just don't wake up. But it doesn't always happen that way. And sometimes people live a long time with serious problems.
Ready?
Yeah. Okay, bebé. La enfermera le va a chequear la espalda, okay, chiquito?
Nearly 2 years ago, Antero Pallarosa was sent home from the hospital with a tracheostomy and a feeding tube. But even with the help of 2 home aides, paid for by Medicaid, his daughter Carmen still quit her job to care for him.
You have very good technique, just like a hospital, better than a hospital.
Yes, only this with, you see?
Well, the care that she gives him is really expert care. I mean, she hasn't had medical training, but she's learned everything about his care to the nth degree. So she knows how to take care of all of the equipment that he has. She knows how to feed him. She knows how to take care of his skin, how to take care of his trachea.
Time for food.
But think about it. I mean, it's a one-to-one caregiver-patient relationship, 24 hours a day, 7 days a week. You can't get that in any institution. That he just never would have been taken care of that way.
¿Qué, mi amor? ¿Qué? ¿Qué, papito? ¿Qué? Okay, papito, no hay problema, okay? Tú puedes dormir. You can sleep, okay, baby? ¿Ah? Tranquilo.
Okay.
Some people feel that their kids are their ace in the hole. They'll take care of them. It's not always the case. I don't have kids, for instance. I really seriously have to think about what's going to happen to me when I get older. And it's kind of a scary question. I think we all want to postpone it. I know I do. I don't really want to think about it right now. But I'm faced with it every day because I see it in my work.
Miss Janice? Hi.
America is still a country which believes that the people who should care for the elderly are their members of their own family. But that is now an increasingly difficult task for families. People are having fewer children. Families are smaller, less stable, geographically spread out, and the time of caregiving has gone from months before death to years, and in some cases up to a decade or more, where people simply are living longer in conditions that are deeply needy. One study, a very, very telling study, shows that only those people who have 3 or more daughters or daughters-in-law have a better than 50% chance of not finishing their life in a nursing home or an institution.
Long-term care services right now in the United States. Again, depending on what this new health policy does, those we're going to see some changes potentially, but right now, Medicaid and Medicare. Medicaid in the state of Texas is reimbursed on what's called a resource utilization group, a RUG rate. Each Medicaid RUG rate is each medical condition is tied to a RUG rate, and the RUG rate is reimbursed. RUG rates are based on the amount of resources it takes the facility to care for an individual, and the more resources, obviously, right, the more resources it would take you to care for someone, the higher reimbursement rates. I will show you this, but we don't, you guys, just for your information, and if you have any questions about it, please feel free to, I think Tony has my contact information, and we'll put it up maybe with the slides. I can talk to you more about RUG rates, but I think we wanted to end with a roundtable, so I'll go through this and just give you some information about RUG rates. So this is how it works. A person, Mr. upon assessment to admission to a nursing facility, the team decides she needs all these therapies, PT, OT, speech 5 days a week for an hour a week. And they assess her ADL score, like how many activities of daily living, how much help is she going to need. Using that information upon admission, you determine her quote-unquote RUG rate. So this is how it works for Mrs. Smith. She had an IV tube. She had an IV tube, right? So that puts her. She had IV medications, so that would put her at one of the highest levels of a RUG rate. She's getting rehab across the 3 groups: the PT, the OT, the speech. And you take the number of hours that or the amount of time that she's requiring therapy. You multiply that out by the week. You take her ADL score and this ADL index, and you find out what her RUG rate is. For her RUG rate would be the RUL. And on the slides, when you go back and take a look, you can go to this website for Texas Medicaid, and we'll tell you how much the facility will get reimbursed for her care. So that's how in the state of Texas we reimburse for a stay in a nursing facility right now. Again, it may change based on the legislation, but right now this is what we're seeing. Healthcare expenditures are being affected by consumerism or consumer-directed healthcare. We talked at the beginning of this lecture about the responsibility on the patient to make some healthcare decisions for themselves. Plans are requiring consumers to make decisions about how they want to spend their healthcare dollars. Consumer-directed healthcare appears to have developed because of the failure of both regulation and market forces to produce satisfactory cost containment. So because the healthcare system could not cost contain itself, we're going to put it back on the consumer. And when you think about all the health literacy issues that you guys have discussed over the course of this lecture, the complexity of making some of those decisions, the consumer decisions, can be really complicated. And when it comes to the patient, and when they're in a state of, they're elderly or they're frail or they've just had a medical episode, making some of those medical decisions based on cost or cost containment or what their claim is going to cover. It can be a very difficult and very challenging time in which to make some very serious decisions. So how realistic is it to expect the patient to take charge of their own health care? I have an example in here, and I'm just going to leave it, and you guys can go back over it later. And the example is discovering what your own costs can be. You fell over the weekend, you know, your arm is hurting, you went for an x-ray, the bone's not broken, they send you home, you have a prescription, and they want you to come back the next week. How many people are you going to get bills from? I mean, you're not just going to get bills from your PCP, right? You're the person who looked at your arm. You're going to get a bill from the person who did the x-ray. You're going to get a bill from, who else would you expect to see a bill from?
Radiologist that read the x-ray.
That's right. I mean, there's just, you know, it's not so simple. And, you know, you're going to get a bill from your pharmacy when you take pain medication. So you manage your pain medication. So there's another bill. So determining your own costs is incredibly complicated. And there's an example of a healthcare plan if you want to take a look at it and determine how much the cost would be from this, or you can use your own health plan. But it's really complicated to determine or anticipate. And so how are you going to anticipate that? How are you going to save for that? How are you going to be prepared for that? So anticipating what your responsibility is just for a small event like this is really complicated. And again, I go back to the case that I used when I had the baby. If you don't know enough about your health care plan, you may just, you know, write the check, or, you know, maybe not write the check, and something happens and it goes into collections, or not knowing enough about your health care plan it can be really bad, but it's so complicated. The healthcare system and the healthcare plans themselves are so complex. Did you have a question? Sorry. No. Has anybody ever had this experience where you've utilized your own healthcare plan, and then gotten bills in the mail and you're like, what is this bill for? Well, who is this person? Did I see this person? Yeah, I mean, it's incredibly complex. So some strategies that address the challenges to navigating the U.S. healthcare. So how will we address the complexity of the U.S. healthcare system currently? Some of the efforts that we're doing to make the healthcare system a little bit more user-friendly, we'll say, right? Simplify the language and check readability of any documents. If you've ever used it, Microsoft Word has a program where you can check the readability, and it'll tell you what grade level a document is. Reformat materials to make them user-friendly. Confirm patient-client understanding. Don't just ask the patient, do you understand? Well, they're probably going to say yes, right? Ask someone to give information back to you. Train agency staff or healthcare providers about literacy. Use audiovisual aids. Provide materials in multiple languages. All of this stuff is what we're currently doing. Use pictographs, cartoons to instruct and form. Test reading levels in clients. Use interactive or kiosks. So computer kiosks to provide information. Potential implications of the new health legislation to the challenges of navigating the U.S. healthcare system. Is anybody very familiar with what the new legislation said? Has anybody read it? I don't know. Is it available online? Probably. Of course, right? I mean, I haven't read it, but I don't know anybody who really has read the entire thing.
If anybody knew what it was, it would have been out.
I'm sorry.
I think if anybody really, truly knew what it all said or what they decided, it would have been somehow in a shortened form somewhere.
It's incredibly complicated. And you know, one of the great examples of how complicated legislation can be is the Medicare system. And the addition of Medicare for the 65 plus population, but also for, again, I told you that little carve-out subsection of the population of people with end-stage renal disease or kidney failure. That got attached to the healthcare bill. So, I mean, things get really complicated, and legislation can be very complicated. But this legislation potentially will add another 32 million people to the ranks of the classified, those classified as insured. This does not include undocumented immigrants, currently estimated to be 12 million nationwide. This expanded coverage will not take place immediately, rather it will be phased in over the next 10 years. The legislation potentially focused or is designed to shift focus to prevention and wellness, which would be fantastic. Favors reimbursement to primary care practitioners and caregivers in rural and underserved areas. Provides for accountable care organizations, local health care organizations, and related sets of providers that together can be held accountable for the cost and quality of care that they deliver to a defined population. Calls for doctors and hospitals to bundle services related to specific diagnoses and treatment, diabetes, transplants, hip replacements, under a single comprehensive charge. Services must be evidence-based and quality-focused to save money, and encourage medical or health tests. It calls for centers to test the effectiveness of healthcare delivery modules, establishes large group purchasing organizations, and requires a 340B pharmaceutical pricing, reduces overutilization by preventing physicians with personal financial interests in hospitals, imaging centers, and other healthcare related facilities from referring patients to these facilities. The anti-kickback legislation, if you've heard anything, we already have something like that, but I guess this would strengthen that. Strengthens fraud and abuse regulations, provides additional reimbursement for physicians and practitioners at rural hospitals, adds programs to reduce health disparities, and provides additional funding to FQHCs, federally qualified health centers. So based on the new legislation, what we see is some of the challenges that we may face. So if we institute all of these things, shift to prevention and wellness, reimbursement to primary care, do you think it's going to make things better for the seniors or worse? Or do you think it's going to do anything?
Well, according to this, it's going to be better.
Right.
If you've seen the senior news in May edition, this is exactly what we're talking about. There's more clarity emerging on the healthcare reform law. For example, in terms of preventive services, those right now are on Medicare are part of deductible and copay. They're not going to be. They're going to be. They won't be on your deductible or copay for Medicare screening. Those are going to be, free services recommended. If you do the recommendations per year, they're going to do something about supposedly the donut hole, for the medication use. It's just a lot of improvements that, like some of them that Amanda talked about, reducing fraud and abuse. And mostly there's not going to be much in terms of Medicare cuts initially, or any changes to begin with, but that's going to gradually be filtered in. So we'll see. But if I'll try to get more copies of this if you ever want to see it. I'll leave it out here. This has a nice little summary. They just sent it last month.
Yes.
I take issue with the prevention and wellness care in the elderly because right now I don't see insurance companies. They write it into their plan because it sounds appealing. Yeah, we're going to prevent and keep you well. But they really don't cover it well, and when you get to be 70, 80, your doctor doesn't want to do a PSA on you. Your doctor will say, well, that's not necessary to treat your cholesterol level at this time and point. Yeah. So I don't see that as a big benefit to our elderly, having a shift to prevention and wellness. They've already got several comorbidities by the time they're 70, 80 years old. So I see that as it looks nice, but it's not worthwhile.
And then if you do find something wrong, who's going to pay for that?
Yeah.
Now
exactly.
We know you have this or that, and to prevent it, like you're saying, we're going to put you on cholesterol pills for $100 a month. And she's like, I can't afford that. So now you've told me I had this, not to worry more about it.
It looks good, looks great in writing, but it's not practical.
Right. I agree. And then do those facts that it's supposed to fix or make something better really materialize. For example, what you're talking about, like if the preventive services are required. If it's something written that it's recommended, as you know, that may go for those services. Basically, this is supposed to increase the likelihood of payment to the doctors and reimbursement for those services. But that will also motivate them to get their patients to get the preventive services if they're going to get their reimbursement in a more efficient way. I don't, you know,
See, I think Medicare,
will that really happen?
one of the docs I used to work with was family practice. He said that Medicare had quit paying for like the yearly physicals and all because they said they weren't helping. They had done a study of several groups of individuals and they were, yeah, exactly.
Didn't provide better care.
So it's almost like we're reinventing the wheel that was already invented. And it's like, what have we learned from like the bundling? They did that back 20 years ago and they went, that didn't work.
DRGs, diagnostic related groups.
Exactly.
Yes.
And it puts a lot of pressure on the healthcare provider, office, clinic to know all these rules and all the changes and try to make it work so that they do get some reimbursement. It's going to take 10 years to get a few answers.
Yeah, then the amounts of like we're talking about the donut hole with getting, if you're, basically if your medications aren't covered and then they get lost, you have to pay an extra amount up to once you reach this cap. I said, well, okay, we'll get reimbursed up to a maximum of $250. Ooh.
Yeah.
You know,
right.
Like, I'm sorry, I don't mean to be cynical about it, but is that going to really make that big of a difference?
Well, and is prevention and wellness really throwing pills at something you identified, or is it spending time educating them before they ever get the disease, or about what the potential is for whatever their lifestyle is? And I don't think they're
And in
really
10 minutes, what can you tell somebody?
I don't think that they're taking that into consideration. If you have more people that you're going to have to provide those pills for, that service isn't going to go very far.
And then they talk about rural hospitals providing additional reimbursement for doctors and practitioners at rural hospitals. So now you get doctors enticed to go there. What have you got for equipment in these hospitals? Now you're liable because you're trying to keep up with the Joneses in the urban areas. And well, my dad went to rural Timbuktu and he died because you didn't have an MRI to tell me he had cancer. So I'm going to sue you and we're right back where we started from again, digging a deeper hole. I don't know if there is a universal healthcare for everybody.
Well, I don't know. But I think it's going to be very interesting to see how this all plays out in terms of what happens to the senior population. And again, you know, we talk about the complexity of navigating the U.S. healthcare system. Is this going to make things simpler, or is it going to make it more difficult for people? I mean, I think probably the general idea behind it was that it would simplify it by having a payor, right? But I don't know how it's going to be simplified.
May I ask you a question? You're ethical trained,
okay.
PhD. So with this coming out, there's already been a lot of discussion as far as abortions being paid for and universal. What about transplants and how many transplants and, you know, all those other that go with that?
Right.
What do you think? If you were going to sign a bill that included
would I
this,
sign this bill?
what would you, what do you see? And I know that's a loaded question. But
I don't know. I really don't know. I mean, again, I have not read the legislation, so I don't know enough about it to give you an intelligent answer about whether or not. But I'm on an ethical front in terms of providing health care to the bill itself, to provide the idea of providing health care for people who are uninsured, I think is probably pretty ethical, because you want to level the playing field, right? You want to provide people who don't have access to health care some sort of access to health care. And my biggest issue when we talk about doing some kind of universal health care is insuring people doesn't guarantee access, and we all know that. We all know that if you have insurance, doesn't necessarily mean you can go to the doctor, you can find a doctor, you can pay for
lines of the ethics, I was thinking, and I want to eventually open it up too, because I'm seeing a lot of talking going on in the other sites. So you all can unmute in your other sites and join the conversation if you'd like. I was thinking like with the videos, it breaks your heart. But like the man with the feeding tube and time for dinner, pouring. I mean, what kind of life, And so the ethical, keep it going as long as possible, and when do you let go?
And who makes that decision?
And who makes that decision, exactly.
But like we talked about when we were talking earlier at the break, that's not always the case. I mean, some of these, obviously it's PBS film, but we're trying to show some of the extreme cases. So it's not, some of these issues or the videos are very extreme cases of long-term care, just to provide you with an example. Not everybody ages like that. So I don't want to paint a grim picture of aging, but just to kind of give you an idea. I want to give you a full picture.
No options. You either grow old or you die.
Well, that's a life reality, right? I mean, it happens to everybody. But just to give you all of the issues that are facing everybody as they navigate the healthcare system, and then realizing that navigating the U.S. healthcare system for the elderly is not just their issue. It's our issue, it's their children's issue, it's the financing side of the issue. There are so many people who are involved in helping seniors navigate through the healthcare system. It's not just their responsibility. It affects everybody.
Well, one thing none of these dealt with was these are people who either have the capacity to pay for this care or they qualified to have it paid for them. Right. It didn't cover that big gap where you have just enough money to not get government help but not enough money to pay for care.
Right. And I would imagine that group is increasingly growing. That group that is kind of
a lot, I think, in all the videos was how difficult it is to communicate with an older patient who has difficulty speaking and hearing, and then how do you get that information across? And hopefully that's been, we've been able to address that, I guess, in the series a little bit.
Yeah.
What about, isn't one of the sticking points, I guess, is that either initially or eventually they're going to cut reimbursements to Medicare physicians, and so supposedly Medicare physicians are going to opt out of Medicare, and so we may be expanding coverage, but you won't be able to find a Medicare provider in your town.
Right. That is definitely an issue. Yeah.
So.
I mean, they got to pay their bills back that we were discussing. To go to school. Money's got to come from somewhere.
I know with the hospitals, if you qualify as a nonprofit organization, or you're a nonprofit organization, a certain percentage of your patient population has to be Medicare or Medicaid. Now with physicians, I don't know. But, the idea may be the volume of patients. You may have lower reimbursement, but you have an incredible volume of patients that make up for that. I guess I don't want to say it like this, but the Walmart mentality, right? You have a low price on something, you offer a low price on something, but you sell 1,000 of them versus offering right at a higher price and selling 100 of them. So there's volume.
But that's what you were talking about before with the visit time. I mean, that's pretty much inversely related to quality as well. So
right.
The whole thing just disaster.
Yeah, I mean, it's like I said, it's going to be very, very interesting. And the problem is that navigating the U.S. healthcare system is difficult. I feel like I'm a relatively educated person, and it's even hard for me.
Okay.
And so you can imagine how difficult it's going to continue to be for seniors and their families. They have to all be educated on the U.S. healthcare system to help get the services. And I feel like you really have to fight. You have to fight for people. Fight with your insurance company. Fight for things, and that takes the time, and that takes the effort, and that takes the know-how to fight for those kind of things. So.
Any other comments? Any comments from the other sites?